So, how do you document moving a patient from where you find them to the ambulance stretcher? That's the topic for today's show. Hello, everyone. I am Kevin Kelly. He is Paul Gerard with Gerard and Associates, your national EMS CQI consulting firm, and you're listening to the GNA Way EMS CQI podcast. Please check us out at www.gerardassociates.com, Podbean, Apple Podcasts, Spotify. We're on all the biggies. You name it, we're on it. Paul, let's jump right into this thing. Traps for the unwary EMS provider when moving and documenting the patient move. My first question for you, Paul, is how does this documentation issue even come up?
All right. Yeah, that's a good question. Over the last few years, we've been seeing our auditors in particular have been putting in their audit notes recommendations for providers to explain how they physically move the patient. And, when I first heard that, when I first saw those, I was thinking, maybe that's getting a little too detailed. Maybe that's a little too nitpicky. Maybe, but the reality is over the last 19 years that we've been doing CQI, we've had a number of cases where providers didn't move the patient properly and or didn't document how they moved the patient. And in some cases, the patients had downstream complications. So there was a case a number of years back where a little lady had fallen and she heard a pop in her hip. She dragged herself to the couch, sat herself on the couch. She's in a sitting position. So the crew came in. Yeah, I hurt my hip and I heard a pop. Okay, can you move your leg? Yes, I can. Okay, can you stand and pivot to the stair chair? Sure. So they stood her up to stand and pivot. And in the process of her doing that, she put some weight on that hip and she heard another pop, a second, and cried out in some pain. So clearly that's not the best way to move her or treat her. And how you move the patient becomes relevant. And interestingly, as we've sent these calls to the medical directors, we thought that sometimes the medical directors would poo-poo this. And in fact, we've gotten a lot of medical directors who started to sign on board and say, yeah, you should be talking about how you move the patient. So that's where it's kind of come up. The problem is when you say this to providers, they sometimes kind of roll their eyes and feel like you're getting nitpicky with them. But once you start to explain the reasoning and the rationale, they generally start to say, all right, I kind of get where you're going with this. And then they start to put it into their repertoire.
Yeah, and I guess maybe the first call to action to those paramedics and EMTs that are listening to the show is stop with the nitpicking defense argument.
Right.
It doesn't work. I mean, it's as somebody who wants to reduce risk and keep patients safe and keep our EMS providers safe, you want nitpicking. you want constructive nitpicking.
Yeah, right. It's going to be helpful.
It's got to be fair, right? Because you can't have Gerard picking on Kelly and not picking on Smith. It's got to be, if you're going to nitpick, you got to be fair, and that's where I think nitpicking gets a bad rap because it's nitpicking without fairness equals bias and hostile work environment.
It's either not equally applied, and we're equal opportunity nitpickers, right, here at Gerard Associates, right? We pick and I say that in jest, but the reality is the auditors all audit every call the same way, so there's not a lot of that bias.
Yeah.
But the other issue is that it's never a problem until it's a problem, and that's what providers don't understand. They maybe have been documenting a certain way for a long time. Nobody's ever said anything to them. Some little old lady never had a problem with her hip from the way they moved her, or at least that's not how they document it on their run report.
Right.
So they think it's much ado about nothing. But the reality is there can be issues and problems here, and it needs to be documented thoroughly and well.
All right. So we want constructive nitpicking, or we as paramedics especially, we as one percenters, and those that strive for excellence, we want every tidbit and data element that we can to provide better patient care.
Right.
And that means providing better documentation, reducing risk, reducing liability. So that's call to action number one. But huge liability and risk, I think, in moving patients in general. And there's liability for the provider if the patient isn't moved in accordance with statewide treatment protocols and reasonable care. Certainly liability for the patient. The patients get
Yeah.
injured. And also, moving patients requires effort on the part of the EMS provider, and EMS providers can get hurt.
Right.
And when EMS providers get hurt, we have the ever increasing concentric circle of, issues with workman's comp. And, hey, some people never come back to the game. So you want as express documentation and as explicit documentation as you can. And you certainly want that documentation if you are a paramedic that gets injured, or you have to defend your actions if a patient gets injured. You want that documentation to match the other documentation.
Yeah. And also keep in mind. Oh, sorry, Kevin.
No, go ahead.
What was that?
Yeah.
So also keep in mind that a lot of you're going to be honest about this, right? So we had cases where OEMS came down to conduct an investigation, and in the process of conducting that investigation, she interviewed the providers. They said, what happened? Okay, how'd you move the patient? Well, we put him in a stair chair, took him out to the truck. And then they go to the patient. They interview the patient, and they say, no, they never put me in a stair chair. I walked all the way out and stepped into the ambulance myself. So, you got to be honest about this stuff and not try to fudge your way through the documentation process. And what a lot of providers do, and here's the nuance of this, right? This is the difference between good, better, and best. Good is when a provider will put something like put patient in the stair chair, then we put him to the stretcher, then we put him into the ambulance. And that's, that's good. At least it implies that you use the stair chair and a stretcher at some point in the process. But that's not best, right? Best is, how did you move them from the Barco lounger or the lazy boy chair to the stair chair? Did you do a stand and pivot? Did you have a provider at the head, one at the knees, under the knees and under the armpits, and move them to the stretcher? So there's a variety of ways, and the same with how you got them from the stair chair to the stretcher. And even one physician wants providers to document how they move the patient from their stretcher to the ER stretcher. And that seems like the ultimate nitpicky, but the reason that medical director wants that is because there was an incident at his hospital where, in the process of having the patient move over, the patient slipped between the EMS stretcher and the hospital stretcher. This stretcher separated. The patient was self-moving, right, using their hands to kind of drag themselves over. They used their legs to kick off of the EMS stretcher. A crack formed between two stretchers. Their ass went into the crack, and they started to fall. And the providers pushed the EMS stretcher because they saw it happening. Just with their hip, jammed it up against the other stretcher and kind of wedged the patient between the two, so they didn't go all the way down to the floor. That's the good news. The bad news, they started having hip and leg pain from where the paramedic jammed the stretcher in to catch them to wedge it. So that physician says, no, I want providers to describe, when they get to the hospital, did you use a slide board? Did you use a 2-person sheet shift? Did you use 4 people to do a sheet? Did the patient help themselves over to the stretcher? I want providers to document that on their EMS run report. So to that level of detail, some physicians are asking for how the patient was moved.
So not only are we documenting, well, the recommendation is to document how you move the patient from where they were found at the scene to the ambulance stretcher with specificity.
Right.
We have medical directors that are asking for similar documentation when we transfer the patient from the ambulance stretcher to the hospital bed in the emergency department.
Correct. Some are. Yes. Okay. Yeah. Yep. And right. Once they see, once this topic becomes a topic, right, becomes an issue, and it's usually something in the field where one of our auditors will say, okay, so you had a patient with, who had an ankle injury, and you had them stand and pivot on their good leg instead of lifting them onto the stretcher, and the auditor will question that they shouldn't do it that way. That's not in the patient's best interest. And once the medical directors get a taste of that, they start putting 2 to 2 together and saying, yeah, well, if that's the case, if we're asking them to document with that level of specificity how they physically move them to the movement device, right? How did they move them to the stretcher or get them onto the stretcher? Then they start connecting those dots and saying, well, they should be doing that for the move here at the hospital as well, or whatever. So yeah, that started to pick up steam over the last few years with medical directors in particular. And we know that providers have gotten in trouble from OEMS for bad moving techniques. And the problem is they don't document it well. Even if they do a decent, proper move, they often will say something like patient 2 was moved to the stretcher, the stair chair. They were then moved to the stretcher, but they don't physically say how. So how did they get from the stair chair to the stretcher? Was it a stand and pivot? Did you lift them, off the stretcher? And if you did, to what degree? And then there's a lot of subtleties and grades off of that, right? So some of the ways the auditors will recommend. I have one auditor, I'll actually read it off my list, but this is how they itemize the list when they do the audit. They put, please describe, was a stair chair used, scoop stretcher or longboard used, was a stand and pivot, was it walk assisted, was it walk unassisted, or was it lifted? And if it was lifted, was it 2-person, 4-person, or more? So how did you physically, to get them onto the longboard, did you log roll them, or did you just have the patient slide their ass over to the longboard for you? So how did you physically do that? When you say assisted patient to walk 3 steps, 4 steps, 5 steps to the stretcher, to what degree was he assisted? Because you and I both know, and we've all at some point had it happen where a patient looked fine. You went to stand them to move them, and the patient syncopated, or they got dizzy, lost their balance, and then you're grabbing, trying to grab them to prevent them from falling. Well, that means you probably weren't really close to them and, giving them some guidance and holding them onto them well to begin with. You didn't have those arms, on either side of the patient, holding the patient by both sides of the arms and trying to guide them to the stretcher or whatnot.
And that's where providers get hurt.
Yeah. And patients.
Yeah.
Yeah, absolutely. So big risk area. And this is one of those cases where it's not a problem till it's a problem. But when it becomes a problem, now everybody's kind of, browning out their shorts because they're worried that they know that if there's an investigation into this, they're going to get jammed up because there's no justifying some of these move tactics. And that is often seen when something bad happens.
Right. And, we mentioned that the documentation has got to be consistent. The EPCR from the ambulance needs to be consistent with the documentation, the nursing notes, and all of that. But it's also got to be consistent with what is seen on Ring camera, doorbell footage, iPhones, all of that as well. Because I'll tell you, we're the biggest reality TV show out there right now, EMS, because we're being recorded all the time. We're in a fishbowl. And, unfortunately, we're seeing some documentation of how patients were moved that doesn't jive with the Ring cam doorbell footage.
Right.
So that's a big problem. Vulnerable patient populations. I mean, so the ambulance comes to pick me up, and cardiac issues, and all the old person. I get some joint problems, but I really don't want to. I don't want to be picked up and moved, and so I'm the type of patient that might just jump up and assume that I'm supposed to plant my ass on the.
Right.
How about documenting that the self-ambulatory moving patient that has a mishap while self-ambulating to where they think they need to be?
You should be advising that patient that you don't want them to move, and that the preferred method for them to be moved is whatever the preferred method is, and treat that to some degree as a refusal, right? So the patient says, I can stand. I don't need you to lift me. I can stand and walk over the stretcher. I don't advise it, sir. You're having chest pain. You're pale and you're diaphoretic. You might be having a heart attack. I don't advise that you walk to the stretcher. The patient says, nope, I'm walking to the stretcher anyway. And this is the only way you're taking me to the hospital. And if you feel that you've tried everything you can to convince them not to move in a manner in which you don't want them to move, then that's got to make it to the run report documentation, right? That everything else the patient complied with, let you put an IV in and give him aspirin and nitro, take him to the hospital, everything, take his vitals, do it 12 lead, let you do everything else. But he adamantly refused to be lifted and carried. And some patients will do that. And you know this, they just don't want to be lifted and carried. Others are fearful. Hey, I weigh 350 pounds. There's no way I'm letting you two guys carry me down a flight of stairs in a chair. Right. Other people have been carried downstairs in a stair chair and didn't like the experience, and now they don't want to go through it again. So it's incumbent on the provider to advise the patient of the best, what's in their best interest. Do everything they can to persuade that patient. And if the patient still refuses, that should go in your run report as a refusal of that element of the call. So it shouldn't just be treated as patient said he wanted to sit there to walk, so I let him walk kind of thing. You've got to go a little further than that and make sure you advise them properly. Most regulatory protocols actually have some sort of language that says do not allow the patient to exert themselves, or do not allow a patient to walk, some of them outright say, which implies that every patient has to be lifted or carried in some manner, right? So, depending on what your local protocol says and the exact verbiage in it might give you some sort of leeway for letting some of these low-level patients do some minor walking, but even that should be described. There's a big difference between I let them stand and walk 3 steps to the stretcher versus I let them stand, walk out the hall, down the stairs, out the garage door to the ambulance, where I then sat them on the stretcher and loaded them into the ambulance, right? Big difference between those two, especially in the case of that patient having chest pain or shortness of breath. So you don't want to allow them to exert themselves. What we're seeing a lot, Kevin, is we're seeing a lot of providers these days don't seem to like their stair chair anymore. And we're seeing a lot less patients getting stair chaired, and it's kind of they're good enough they can get on the stretcher themselves, or they're not good enough and we've got to basically, drag them because they're in that bad of a shape. And providers seem to be trying to get out of doing the stair chair thing. And I get it. It's not easy. It's not fun. You sweat your ass off in 90-degree heat with equipment strapped to your back and the patient breathing in your face if you're at the bottom of the stair chair. There's all this craziness that's not necessarily fun, but you can't allow the patient to do things they shouldn't be doing so that it's good for you and convenient for you. You got to do what's in the patient's best interest.
Well, it sounds like, that issue of moving patients on a stair chair. Now they have the stair chairs with tractor,
right?
Type of thing. I did a service. Where was it? Pennsylvania, Cumberland Goodwill. Great service. They're in Carlisle. They actually, at their headquarters, bought the house next door, and they set it up just like any house, but it's all decked out with all of the necessary equipment, and it's a training facility.
Great tool.
Yeah. But what you're required to do to get out of their academy and also to get on the truck during your onboarding is you have to move patients. You have to, and you're recorded. You're recorded. Yeah. It's all recorded.
Perfect. Yep.
All, instant positive feedback, but you got to demonstrate how to safely move. And I think the scenario that we had talked about when I was out there was, the patient cardiac arrest or whatever that's wedged between the toilet and the wall.
Yeah, right.
That's on the 3rd floor, right? So all kinds of, you got to get them out of that position, onto a board, down 1 flight of stairs, 3 flights of stairs.
Right.
And, you're getting constant feedback. But the other thing you have to do is you have to do the run report afterwards, and you have to document exactly what you are suggesting to document. Yeah. And you get multiple repetitions of doing this throughout your training there in all kinds of scenarios, from the bed to the stretcher, from the Baca lounge to the stretcher, wedged between the toilets. You can predict, generally speaking, where people are going to have their MIs and the events and need to be moved. Yep. So you cover all those, and you may get part of that training. And part of the recognition was that significant liability, obviously, with moving patients, the patient and the provider, significant workman's comp injuries, you want to reduce that. So the more practice, just like anything else, the more practice you get doing it, the better you're going to do it, and the more safely you're going to do it on behalf of the patient and on behalf of yourself. And that includes the repetitions of documenting that process as well.
Right. Yeah.
But what I wanted getting back to vulnerable patients, special circumstances when documenting the movement of cardiac patients. Let me back up. Vital signs, neuro, from when you find the patient, and then vital signs, neuro, pedal pulses, when you put the patient in the next phase of the transfer, whether that's the stair chair or the stretcher, Paul.
Yeah. See, that's one of the things that auditors look for, at least good auditors, CQI auditors look for, right? If you have a patient who is having 2 out of 10 chest pain, and you say, so we assisted the patient to walk to stretcher, and that's all you put in your run report. And then a few minutes after that, you say patient's pain increased substantially. It's now 8 out of 10. The dots that are connected, if you're a CQI person, is did they move that person properly? Because if they allowed them to walk any significant degree, did they actually cause potentially that increase in patient's chest pain, right? A potential worsening in their condition. So your CQI folks should look carefully at that movement thing, and they should be looking for the before and after picture. Do they assess their patient fully before they move them? And for folks who are scooping and screwing with patients, right, they just take them out to the truck and do everything, including the assessment out in the truck.
Right.
You're going to see they moved them and then did their assessment after. That's bad. So you want to see they did a full and thorough assessment on scene. They moved the patient properly, describing how they moved the patient properly. And then there should be a reassessment after, right? So that the patient's shortness of breath increase after the movement. Now, some of that could be just normal. The patient is so fragile that any motion at all causes them to become a little more tachypneic, right? That can just happen for a patient. So it is what it is. But the question is going to be, did you cause them to exert themselves in that moving over process that could have exacerbated that? So, even though it looks like it's not much to do a stand and pivot, if you've got a elderly little old lady who's frail, who's a failure to thrive type of patient, who hasn't eaten well, dehydrated, she's got some shortness of breath, just standing her up is going to cause her to maybe worsen her condition to some degree. So, and another category besides into that same category of frail and vulnerable is we're seeing a lot of patients who are hypotensive being sat up and the stair chair is being used as their extrication device. And again, they're doing it in spite of the fact that the patient has an 80 palt pressure laying on the couch saying they're not feeling well. They're then sitting them up, putting it, maybe in some cases, standing and pivoting them into the stair chair and extricating them in a seated position, even though they've got hypotension. And it usually comes down to, I didn't want to go through all the effort to strapping them into a scoop stretcher or a longboard or onto the stretcher and carrying the stretcher, which is much heavier with a patient in it, to do the extrication. So it's a convenience thing for the providers as opposed to what's in the patient's best interest. That's another vulnerable patient that needs to be extricated in the proper way.
Yeah, it's actually on my list, the gerontology patient. So we crossed that one off. What about the cardiac? I wanted to, special considerations for documenting the movement of cardiac patients?
Yeah, same thing, right? If, is it safe to have them stand and pivot? Well, it depends on how bad their cardiac condition is, right? So if they're in an SVT at 180, having significant, massive crushing chest pain, elephant sitting on my chest, and they're pale and diaphoretic, you probably don't even want them to do a stand and pivot.
Right.
If it's just mild discomfort, I've had it for 2 days and blah, 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 and the stretcher's right there or the stair chair's right there, having them stand and sit might be okay in some cases. But the reality is, you don't want them taking the more steps they have to take to get to the stretcher or the ambulance or whatnot, the worse the problem is.
Right. Yeah.
So sometimes providers will say to me, we had him walk to the stretcher, but he was having chest pain. It was only a few feet. Well, how many feet? Well, just 4 or 5 feet. Okay, so he's having chest pain. You put him on the monitor. You see some weirdness on the EKG that you think may or may not be STEMI related. You're concerned for him. Even 5 feet is an exertional thing for somebody experiencing chest pain. And sometimes providers don't see that. They say, nah, he was stable. He was fine. He didn't look like he was in any discomfort. He wasn't pale and diaphoretic. He was conversing to me like we're conversing right now. He seemed very comfortable. So it didn't seem like a big deal to walk him those 4, 5, 8, 10 feet. In some cases, we have very egregious examples where they walk the patient down a flight of stairs with chest pain because they thought it was the best way to get the patient out. And it really is not, right? You really have to prove that if you have to violate a proper lift and carry technique, you better prove on your run report that was the only way to do it.
Yeah. Another, I think this is an obvious one, but the ortho patient and the joint replacement patient.
Yeah.
And, you may not need to be checking neurofunction when you're moving the cardiac patient.
Right.
But you definitely need to be checking the neurofunction on these ortho joint replacement patients.
Yeah. Not just that, but these patients can be tough because you sometimes have to move them in a manner which minimizes discomfort, which can be a weird
Yeah.
It gives me less pain if my leg is up behind my head. Okay, how do I move you in that position?
Right. Yeah.
So you get these really weird. You can't get under my legs and try to lift my knees under my legs in a 2-person kind of carry because it puts strain on my hip and that causes my knee or my hip to be more painful. So you're sometimes kind of stuck. With those patients in terms of how to safely move them. What we are seeing as well on a similar note, is that a lot of medical directors are forcing providers to start pain management before they move the patient. So this patient should get their fentanyl, morphine, whatever your drug of choice is for pain management, before you move them. So that means starting the IV, giving them the drug in most cases, getting and relieving some of that pain before you actually make the move. That's something that should be considered. And another piece of this topic, Kevin, is that a lot of times providers will forego ALS procedures to move the patient, and they do it because, and they'll say this to me when we're talking, they do it because it's more difficult extricating that patient when you have an IV bag hanging, or you're trying to bag a patient,
right?
Or you've got a cardiac monitor attached and those types of things. So people will sometimes say, well, let's just ALS them out in the truck so we don't have to worry about the IV bag getting hung up and being a problem. But if the patient needs their care on scene, that's just not good care, right? That's not good medicine. It's not good for the patient that you're delaying their care so that it's more convenient to extricate. And we were taught how to extricate these patients properly and safely with full ALS. So for providers to say, yeah, well, it's inconvenient to have an IV hanging while I'm trying to put them in a stair chair and carry them down a flight of stairs. Well, you should know how to do it. You're a professional. You should know how to do that. You should know how to do the most complicated extrications and still provide patient care to the patient, in spite of the fact that some of these can be a little complicated.
Yeah.
So don't let convenience trump patient care.
And it's, I think we talked about it on the last show is, you get out of school and you're required to demonstrate all these proficiencies, including moving patients that have IVs established, who are intubated, all of that. Right. And once you get out in the field, all of that seems to dissipate somehow. You take shortcuts, and shortcuts are just a disaster, and you pick up bad habits. Yeah. Now, remember, there's 4 elements of negligence. It's duty, breach, and that breach is essentially what a reasonably prudent paramedic or EMS provider in that jurisdiction would have done. And quality documentation is something that a reasonably prudent paramedic would do, and documenting the details of the patient movement, causation and damages. And you remember the statute of limitations is 3 years. So you got a lot hanging over your head. I mean, you really have to think holistically about your paramedic practice. And particularly take as much care in documenting what you do as you do taking care of that patient, because that old adage, we can argue it all we want as lawyers, but if you didn't do it, if you don't document it, it didn't get done.
Right.
That holds true. Couple other vulnerable patient populations, Paul. Pregnant females. You see any documentation issues with respect to the movement of pregnant females?
Yeah, oftentimes the providers will. This is similar to a topic we already talked about, but they'll acquiesce to the patient in terms of what makes her more comfortable in the movement process, and that's okay if the patient can otherwise sustain that type of movement. So if the patient says, listen, I'm having really bad contractions or belly pain or whatever their medical condition is, and I'll just stand and walk over to that stretcher. That'll be easier than you guys trying to lift me. And that makes a lot of sense to the provider, right? That trying to lift a pregnant woman is even more complicated. But you have to look at her medical condition, right? If there's something with her medical condition that precludes her from standing and walking to the stretcher or whatever she's, giving her opinion in terms of how she feels you should allow her to move, you need to make her aware of that and try to dissuade her from that. And you need to document that you tried to dissuade her from that, and document to what degree you tried to advise her to do otherwise, because that's going to become very important when people start criticizing you later about the manner in which you've moved her. And this is true for any patient, right? So if they don't take your advice in terms of how you feel you should move them professionally, and they say, nope, I'm going to walk down those stairs. Nope, I'll get up and I'll walk over to your stretcher. I don't need you to lift me up, even though both of my legs are going like this and both of my hips are popped. You're going to walk to that stretcher, damn it. You really want to make every attempt to convince them otherwise, but equally important, not more importantly, but equally important is to document all the efforts. A lot of times, again, good, better, best. A lot of times providers will document, we advise the patient not to stand. And that's all they put.
Yep.
But then the patient stood and they got on the stretcher. So the medic thing or the EMT thinks that they've addressed that in their documentation.
Mm-hmm.
We told the patient not to stand. And they use a lot of other generalities like that, like followed all ACLS protocol for asystole, right? So that's a general statement. Advise patients of all the risks of refusing. That's a generalized statement. And what we do is we train providers to be specific in those details. What risk did you advise her of? In this case, if the patient wanted to stand and pivot and you say, we advised her not to, what did you advise her? To what degree did you strongly advise her? So when the paramedic says to me, Paul, listen, I told her 3 times she needed to go to the hospital. Right. But your run report just says, advise patient to go to the hospital, patient refused, right? So that, just objectively reading those 2 statements, one sounds a little casual.
Yep.
Hey, you should probably go to the hospital. And another is, I said 3 times you should go to the hospital. And then I asked your daughter who was on scene, I convinced her to try to convince you, and she was trying to get you to go to the hospital. Even the cop who was standing there was saying, hey, sir, you really should go to the hospital. You don't look good. Put all that in your documentation, because that shows to what degree you tried to describe to the patient what you wanted them to do. And then if they say no after all that, most objective readers are going to say, well, it's on the patient. You really did everything you could, and it's well documented. It looks like it's really the patient who just didn't want to listen to reason.
Love the 3 times, the trilogies, and juries love trilogies too. Trial lawyers love trilogies. And what I would like to say, if I had the paramedic on the stand, would, or better yet, the patient on the stand would be, paramedic Gerard told you at 1 o'clock to go to the hospital. Isn't that true? Yeah. Paramedic Gerard told you at 1:05 you had to go to the hospital. Didn't he, ma'am? Yeah, he did. And at 1:15, Gerard tells you, ma'am, if you don't go to the hospital, you're going to fucking die, and you still didn't go to the hospital. Isn't that true? Yeah, that's true. And you can't do that if you don't have the documentation to support it.
Right.
Because then you get the other side going after the whole, you were trained to document. You knew you had to document. Gerard has told you forever you had to document. Right. You didn't document. So you got to freaking document this stuff.
Yeah. Yep. Yeah. Yeah. Well said. I mean, that's the more you try to convince the patient, the more you should document that you were trying to convince the patient. And if you called online medical control, so all else failed, you tried to routinely, several times, 3 times, said to the patient you should go to the hospital. Patient doesn't want to go to the hospital because they're a high risk refusal, and your policy says you call medical control. You do call medical control. Document that as well. Document how long the medical director was on the phone for. Were they on for 30 seconds or 10 minutes trying to convince the patient to go to the hospital? So all of that shows that you made best efforts to get the patient to do the right thing. And it's the patient who made the decision not to want to do the right thing. And it's not because you were lazy. It looks like you're lazy if you just say, we advise patient not to, to walk, and they walked anyway. Okay. But, was that really sufficient? We don't know. So, and then it's your word against the patient's, right? So the patient, if they experience some sort of bad outcome, it's going to look like the patient's right, that you didn't try very hard and that you didn't make best efforts, because the evidence looks like it's pointing against you, even if you did make best efforts and you just didn't document those efforts.
That's right.
So it's got to be on the paper. Get it on the paper.
Yep. You got to document it. One last vulnerability on my list, and I think it's the biggest one, is the altered mental status patient, or the patient that has some type of a psychological disorder. Documenting the movement of those patients. Any tips for our listeners?
Yeah, you want to, again, same rules apply. You want to move them in a safe manner, but you also want to make sure that you explain the patient's baseline, right? So if the baseline is acting erratic, they're pacing up and down, they're anxious, all those types of things, that should be documented well as well. So, but it's a similar type of answers that you want to make sure. You had the added component, though, of the safety is not just the physical safety, but the psychological safety for those patients, right? You want to make sure that you're not saying or acting in ways that are going to trigger the patient. So you want to document that. If you do need to restrain them, whether it's soft restraints, just physically holding an arm by each provider as you're walking them, partly to hold them up, but partly to prevent them from taking a swing at you, you want to document those things. Because later on, if things go south, again, the patient gets out of control on you, you're going to have a hard time justifying the manner in which you treated that person and whether you triggered some of this stuff. So what you say to the patient, how you say it, it's important for you to document that you were trying to talk in calm tones, that you got family out of the room because they were agitating the patient so that I could talk quietly with the patient. I tried to de-escalate the situation by advising the patient that we were there to help them and we're acting in their best interest. All that stuff should be added to the report with specificity to the degree in which you did it, as opposed to the general statement, well, we tried to de-escalate everything, but it was still a shit show.
Yeah.
Okay.
Yeah. Any more, Paul?
No, I think that's it. I think people have to get over what we're seeing a lot of is people just cutting corners on this.
Yeah.
And both in terms of what they physically do, not using stair chairs or proper movement devices as they should, whether it's a longboard or a stair chair or a scoop or whatever they're using. And it, trying to walk everybody, right? To walk them to the stretcher, walk them down the stairs, and you really can't. So that's number one. Take good care of the patient, move them properly in the first place, but then make sure you document all the details of how you move them physically so that you can defend yourself in case something happens. We've seen in 19 years, we've seen a number of patients that had something bad happen based on how they were moved, or the patient should not have been moved the way they were, and it ended up with OEMS or as a lawsuit, and the providers got burned. Don't get burned, right? Don't fall for it. If you're a CQI coordinator or officer, if this is not on your radar and you're not paying attention in the run reports when you read them as to how patients are being moved, you need to start educating your providers that this is important, and that they need to get that level of documentation into their report. So that's what kind of my final thoughts on the subject.
All right. Well, thank you for listening, and we hope you picked up some tips on how to document moving patients and how to keep patients safe. Remember that shortcuts are generally the enemy of right doing. There's a treasure trove of information on the EMS CQI page of GerardandAssociates.com. Check it out. For Paul Gerard, I'm Kevin Kelly. Stay safe, watch each other's back, and peace out.
Talk to you soon, everybody.
On 5.